In our session today, we will be examining the Rhabdoviridae, the Polyomaviridae family of viruses, as well as prion infections. Now, prions are, of course, not viruses. They are infectious proteins, but they cause central nervous system manifestations and neurological manifestations, and this is why we included them in today's session. Let's start with the Rhabdoviridae family, which includes the very famous rabies virus. The Rhabdoviridae family of viruses are bullet-shaped viruses. They are RNA viruses. They have a single-stranded RNA genome, and they do have an envelope. These viruses, there's a, it's a big area of viruses. There's a lot of them. They have a very broad host range, and the group includes the deadly rabies virus. If you're not familiar with this disease, this is what we call kalab in Arabic, and we'll be discussing this in a little bit. Now, the rabies virus itself, there are multiple strains of it, but only one serotype. So what does this mean? This means that if you are immunized to one of these strains, you are usually immune to the other strains as well. Some of these strains are wild type, so you'll find them on the street. They are called street strains. You'll find them in dogs and animals out there in nature. But there are other strains, and these are ones that are called fixed, and these are ones that we use in the lab for various purposes. The Rhabdoviridae family includes 7 genera. It's a big family of viruses. It's about 200 species. Of importance to us are the Listavirus and Vesiculovirus genera. The Listavirus genus is the one that includes the rabies virus, and the Vesiculovirus genus includes the vesicular stomatitis virus, or VSV. Now, this virus, this is the last you're going to hear about it in this course. VSV infects usually cattle, and so we don't worry much about it when it comes to human beings, but it can cause flu-like symptoms and can cause lesions as well. These are vesicular lesions that might appear in humans. Now, on the slide, you'll see an electron micrograph of the rhabdo virus or the Rhabdoviridae viruses. Rhabdo stems from Greek and it means rod. So these are rod-shaped, or rather bullet-shaped. Let's delve into the rabies virus. Practically all mammals can harbor rabies. That includes us, but also dogs, sheep, foxes, different types of canines. Bats are a source as well of rabies. On the other hand, you don't see it in birds, amphibians, fish, or reptiles. They do not have this virus. Most human infections are transmitted from a dog bite. That is a worldwide issue. So about 97% of cases worldwide are transmissions from dogs. But in the United States, for example, and other areas of North America, um, they control their street animals, and so the majority of their infections are not from dogs. So that accounts for about 3% of the worldwide number of infections. In the case of North American regions, specifically the USA, they control their street animals, and so most infections happen because of other types of wild canines like foxes, coyotes, and jackals, wolves as well. So how do we acquire this virus? Transmission occurs through broken skin or via mucosa. So this should kind of remind you of the herpes simplex viruses 1 2, which we talked about in the previous lecture. And those viruses also could not be transmitted through intact skin. So infection may occur through a bite or a scratch from an infected animal, or it could also happen if you are exposed to a high titer of the virus aerosol transmission. For example, this is what this picture is indicating here. This is a cave with bats, and so there have been reported cases that people walk into caves harboring these bats, where these bats live, and the rabies virus is present in their urine. So if you are exposed to a high titer of the virus via aerosolized particles, then it is possible to acquire the infection. Alternatively, deposition of the virus on mucous membranes um, could result in infection as well as transmission through transplantation. And there have been documented cases of people acquiring rabies via corneal transplants, for example. The most common way, like we said, by which you acquire this virus is via a bite from an animal. And so the virus gets first lodged in the muscle tissue or the connective tissue. This is the site of inoculation. Now, one thing for you to bear in mind is that first the virus will go into these tissues, into these initial tissues, the muscles, connective tissues. It will stay sequestered, especially in muscle tissues. It stays sequestered there. It doesn't immediately get transmitted to the peripheral nerves. So while it is sequestered, uh, within these muscle cells, it is not really exposed to our immune system. And so we do not mount an immune response. And this is an important thing to keep in mind because you'll see later on that you could possibly actively vaccinate somebody at that stage. So while the virus is sequestered within the muscle cells. So uh, what's happening in the muscle cells is that the virus is replicating, but it is not yet transmitted. This is the incubation period, rather. Um, After the incubation period, the virus will move on from the muscle or the connective tissue and move into the nerve endings. So it enters the peripheral nerves at the neuromuscular junction and then will spread to the central nervous system. So we call this centripetal spreading. Replication will happen there, and then again the virus will spread outwards towards peripheral tissues, specifically peripheral nerves. It goes through the peripheral nerves. This is centrifugal spreading. It will go to various types of tissues, including salivary glands, and the organ with the highest titer of the virus is the submaxillary salivary glands. And so this is why later on people can transmit this virus, or rather, up to this point, we don't know of transmission from human bites. So we don't know really of somebody who had the rabies virus and then transmitted it via their bite, but that is possible because the virus exists in the saliva. But we do know that in animals, this is how this happens. The virus exists in the saliva and then it gets transmitted via a bite. So again, going back, so the organ with the highest viral titer is the submaxillary salivary gland. There are other organs where it has been detected, like the pancreas, kidney, heart, retina, cornea. So we did mention that corneal transplants can result in transmission of the virus. Although it's present in the kidney, or has been detected in the kidney, it has not been seen in urine. So we don't think urine, for example, is a mode of a possible vehicle for transmitting this virus. Um, Usually, once the person acquires the virus, the incubation period is a couple of months, depending on various factors. So, where it was inoculated, and because if that site is quite distant from the central nervous system, it's going to take some time for it to go there. And so, depending on the site of inoculation, its distance from the central nervous system, the age of the subject, the immune system capabilities, all of the above. The incubation period, like we said, is a couple of months, but there has been a range of incubation periods ranging from something really short, like 1 week, up to 19 years. That has been reported as well. So it could take a long time before the disease surfaces. There are three phases of the disease. So early on, there is what we call phase one, or the prodromal phase. This could last from 2 to 10 days. During this prodromal phase, what's happening is generalized symptoms that are not really specific. However, there are some that are a little bit more associated with rabies, such as photophobia, so the person is annoyed by light, in addition to abnormal sensation around the wound site, so the person feels numbness or tingliness um, around the wound site. Now, the next phase is the acute neurological phase or the encephalitic rabies phase. This is phase two. So after the prodrome, uh, then we get the neurological manifestations, and neurological manifestations can surface in two forms, in two possible forms. Furious rabies is the first form. Usually, this phase would last 2 to 7 days if it's furious rabies, and the majority of people who are infected with rabies have this form of neurological manifestation. And here we have dysfunction of the nervous system. So replication of the virus does not really cause destruction of nerves. What's happening is dysfunction of nerves. So you'll see manifestations such as nervousness, convulsions, apprehension, seizures, various types of neurological manifestations that would also include bizarre behavior as well. The autonomous nervous system also shows forms of dysfunction, and so that includes one of the manifestations that the media highly associates with rabies, and that's increased salivation. Um, Other symptoms are lacrimation, dilation of the pupils, hyperventilation, perspiration, whatever you can associate with an overactive autonomous nervous system. Uh, a rather significant proportion of patients will exhibit what we call hydrophobia. This is fear of water. We don't think that the patient is really afraid of water. What we think is happening here is that in their delirious state, when they're drinking water, they cannot really swallow very well. And so this results in spasms of the throat muscles that resemble choking. And so from there on, the person becomes kind of afraid of water. Now on the next slide, there's a link to a YouTube video that I advise you to click and take a look at. Examine that video. This video should show you how hydrophobia manifests. Now, if the person has furious rabies, you have this kind of violent phase, all of the symptoms mentioned here, but then this phase will subside and the person then will succumb to being paralyzed and disoriented. On the other hand, we have the second possible form of the acute neurological phase or the encephalitic rabies, and that's called the paralytic or dumb rabies. If this happens, this is a more slowly progressive type of phase two, and this could last up to 30 days. This is less common compared to furious rabies. So about 20% of people who have rabies experience this type of phase two, which is paralytic or dumb rabies. Usually, this is associated with acquiring this infection from strains that circulate in bats rather than canines. Here, we don't have any of the violent symptoms. What happens is that starting at the wound side, paralysis starts spreading outwards, and so there are no violent symptoms. The depression could occur. Hydrophobia is not really associated with paralytic or rather dumb rabies. It could happen, but it's not really common with that type of furious rabies. Now, what happens after we've seen this phase two? We get to coma, which is the end stage, right? So phase three, coma, and following that, death. Now, not every patient who has rabies reaches this state because during phase two, they might die due to cardiac failure or respiratory paralysis. This might happen before the person reaches this phase, and this is the link I was referring to. So please click the link and check what hydrophobia looks like in an actual rabies patient. How can we diagnose rabies? Of course, besides the clinical manifestations, um, The virus can be isolated, and you can do real-time PCR. It can be done on saliva, on the CSF, also on skin biopsies. More recently, immunofluorescence conducted on a biopsy from the hairline of the neck. So you can do immunofluorescence using labeled antibodies against the rabies virus, and that will help detect infected nerves that surround the hair follicles in the hairline of the neck. Brain immunofluorescence can be conducted, but in that case, the person of course, is already dead or has passed away at that point. There are antibodies that you can detect against rabies in CSF and the serum, so serology exists. Now you can also do post-mortem. You can take a look at central nervous system tissues, brain tissues, and one CPE, the cytopathic effect, is forming inclusions that we call Negri bodies. So in our herpes viridae lectures, we came across the owl-eye formation with the cytomegalovirus. In that case, we had inclusions within the nucleus, which were the replication hub of that virus. That virus was a DNA virus, and DNA viruses usually replicate in the nucleus, and this is why the replication hub was within the nucleus. In this case, the rabies virus is an RNA virus, and so the replication hub is seen in the cytoplasm. So these are called Negri bodies. There is no treatment for the virus, so treatment is symptomatic. You cater to the symptoms. It's supportive, that is. And bear in mind that once the symptoms start, there is no treatment. So early on, the virus is sequestered within the muscle cells, and it's replicating there but has not moved on to the peripheral nerves. And once it moves to the peripheral nerves, this is when the symptoms actually start. This is when the disease starts, and there is no going back. Death is inevitable at that point. Um, However, we have few rare survival cases. Uh, Up to date, I believe around 7 cases of survival have been reported with rabies. So although we don't have any treatment, once the symptoms start, there's no going back. Inevitably, the person will die. We know that we can still prevent this. And the silver lining here is that the virus is sequestered in the muscle cells. This means you can mount an immune response against it at that point, which should prevent its passage from the muscle cells to the peripheral nerves. So there is a prophylactic pre-exposure active vaccine, but it's not recommended for everybody. It's recommended for people at risk, animal handlers, or other types of occupation that might include possible exposure to the virus. Post-exposure, what you should do is clean the wound site. You should give both the active vaccine and the passive vaccine. So the passive vaccine is, of course, antibodies against the virus, and the active vaccine will induce the immune system to act against this virus. Again, mostly because the virus is sequestered at that point within the muscle cells. So this is one of the rare cases where you can use active vaccination after you have acquired the infection. So this can really significantly reduce the mortality rate. Community measures should be taken as well for prevention. So this is an important public health issue. Animal control, immunization, public education, and surveillance of street animals. As for vaccines, there are two types, like I mentioned on the earlier slide. On the earlier slide, there is passive immunization, where you use immunoglobulins against the rabies virus, and there's active immunization, and there's a lot of active vaccines against this virus. Of course, you don't have to worry about all of these, but I just wanted to include some of the historically relevant vaccines. One of the earlier vaccines was the one developed by Pasteur and Roux. Nowadays, so although we have like about 16 vaccines or active vaccines for Rabies, the one that is mostly used nowadays is the human diploid cell rabies vaccine, or the HGCV. This is an inactivated vaccine, and this is the most commonly used one nowadays. Now, the next couple of you only see manifestations in the immunocompromised. So let's start with the BK virus. This is a polyoma virus. It is highly prevalent in the population. So about 60 to 80% of the population has already been exposed to this virus. This is an electron micrograph of the BK virus. So if you're an immunocompetent person, the infection is asymptomatic. However, you might rarely see fever or flu-like symptoms. The virus will establish persistent infection in the kidneys and urinary tract. So notice this is a persistent infection. It's not really a latent infection, although some people might call it latent. It is a persistent infection. If you're not too sure about the difference between these two terms, I advise you to go back to the herpes viridae lectures where I went into detail about the difference between these two, persistence versus latency. If somebody already has this virus, like most of us, and then they become immunosuppressed, or they have some disease that leads to immunocompromisation, this could lead to renal dysfunction upon reactivation of the virus when it becomes full blown as an infection. About 10% of renal transplant recipients present with BK virus nephropathy, and that's because they are on immunosuppressive drugs after being transplanted with the kidney. And this, of course, contributes to graft loss. So, what can you do at that point? So, we don't have a good treatment for this, but what you can do is modulate the immunosuppression level in somebody who has BK virus nephropathy. So you modulate the drug doses for immunosuppression, but there have been also some antiviral treatments that are recommended, which could lessen the risk of graft loss. After bone marrow transplantation, it has been associated with hemorrhagic cystitis. Now, the second polyomavirus we will be talking about is the JC virus, or JCV. If you're wondering how the BK and JC viruses got their names, those were actually initials of patients who first had them. And so people in labs, they didn't have the authority to use, of course, the full names of these patients. And so, because that's not really a good idea. And so these viruses became known by the initials of these patients. The JC virus, again, like the BK virus, is common in the population. Up to 80% of the population is seropositive for the JC virus. Again, similar to the BK, we don't expect symptoms in somebody who is immunocompetent, but we do see establishment of a persistent infection, and in this case, it's in the brain. So the persistent infection is in the brain. You worry about somebody who becomes immunosuppressed. If reactivation happens, this might lead to a disease that we call PML, or progressive multifocal leukoencephalopathy. So there's brain inflammation and demyelation. This is a lesion in the brain of someone who had PML. This is, of course, post-mortem. So these manifestations, especially the demyelination, might resemble multiple sclerosis. And so you need to differentiate between these two diseases, of course. Um, the disease has a very poor prognosis, and so it often leads to death. So I'll give you a moment to think about this question. I think we went over this concept a little bit with the BK virus. So what do you think are treatment approaches that are recommended for PML in somebody who is on immunosuppressive therapy? Would you A, increase immunosuppressive medication dosage first and then modulate based on the condition without using antivirals? Or B, you would decrease the doses of your immunosuppressive medication and then modulate. And you might use drugs some of these are under study, they may be useful. C, do not adjust the therapy you're applying, and some drugs might be useful. And D, do not adjust the immunosuppressive medication dosage and apply radiation treatment. All right, so again, going back to the BK virus, this is a very similar concept here. The reason why the virus has blown up again, the reason why it's replicating and causing manifestations is because of the immunosuppression. So what you have to do is actually to modulate, to decrease the immunosuppressive medication. And yes, there are studies on various antivirals that might be useful. Some of them are directly specific antivirals, some of them are anti-malarials actually, and some of them are anti-tumor drugs. So the answer is B. Let's discuss prion infections in this next section. Again, prions are not viruses, they are infectious proteins. Um, but we have included them along with the other viruses we discussed today because they can cause neurological manifestations and central nervous system disease. I like to start things with a definition, just like we did with viruses. So what are prions? These are infectious proteins. They do not have any nucleic acids. And so they are just proteins that can autonomously replicate. Um, and then infect somebody and possibly cause disease. The diseases caused by prions, all of them result in neurodegeneration. All of them are very slowly progressive diseases, so they take a long time to manifest. These are fatal, and we don't know of any treatment that has been successful to date. All of these diseases, the ones caused by prions, they are called TSEs, which stands for transmissible spongiform encephalopathies. So if you take a look at a brain from a normal human being versus somebody who had TSE, you'll see that the brain looks smaller, and that's because it is spongy. And we'll take a look at histological sections from brain tissues so you can see why they are spongy. Now, the underlying cause of these diseases is still theoretical, and there's a lot of research that still needs to be done for us to completely understand what happens with TSEs. So all of these TSEs are associated with one protein, which is the protease resistant protein, or PRP. This PRP, it exists in us. It is the product of a gene on the human chromosome 20, and that gene is the PRNP gene. So it results in the production of the normal protease-resistant protein. So we do have a normal form that has a biological function in us, as you'll see in a little bit. But some malformation in this protein can result in a TSE. So different human TSEs are associated with different mutations of the gene or different formulations of the protein itself, as you will see. Our normal endogenous form of PRP is something that we call PRPC. C stands for cellular. Now, if it's going to become infectious and pathogenic, um, it has to become misfolded. So this is what happens. The PRPC becomes misfolded. And when it's misfolded, we refer to it as PRPSC. SC stems from the word scrapie, which we will be talking about in a little bit. So the meaning of scrapie will be explained to you in just a little bit on the follow-up slide. So this misfolded form is thought to be bad. It's the bad apple that basically makes the other apples become rotten. So it results in misfolding other PRPCs that we have into PRPSC. And once these proteins are misfolded, they aggregate and they form what we call amyloids. Now, although we have PRPSC and probably has a normal biological function. We don't really fully know what these functions are. There are many roles that have been proposed for it, such as roles in memory, apoptosis, cell proliferation, olfactory sensation, the sense of smelling, copper regulation. All of these have been suggested and studied. So PRP is abundantly found in different organs. It's always, though, expressed in the brain. So in the adult brain, this is constitutively expressed. Now, this is the theoretical prion propagation model. This is how we think prions replicate. The normal cellular form is, as you can see here, this is the blue blob, and you'll see that the PRPSC, the misfolded form, can convert this one PRPC. Once this is converted, they can convert these particles can then, or these proteins can convert other PRPCs into PRPSCs, and so you start seeding this, you start forming filaments. This is polymerization. A filament might break up, and so you have what we call fragmentation, so replication by fragmentation. And now these two fragments can become seeded, and you'll have more misfolding of PRPCs into PRPSCs, and this keeps going on and on. Where do we get this PRPSC from? So there are multiple proposed modes. Spontaneous conversion, suddenly it happens, and so this is called sporadic, or a somatic mutation. So the PRNP gene becomes mutated in a somatic cell. Again, this is sporadic, so both sporadic forms happen out of the blue. Then we have what we call the germline mutation, or the familial TSE, and in that case, this is a heritable form of the disease, and you'll see that all of them are autosomal dominant. We also have what we call inoculation type of TSE, and inoculation can be iatrogenic, and this term means from a medical source, so possibly, for example, surgery or transplanted organ. There's what we call the infectious TSE, or consumption TSE, because the person acquires it from an external source, and possibly through consuming the protease protein that is misfolded. Now, different animals, specifically mammals, have different types of TSEs, and all of these TSEs and all of these animals, all of them stem from that PRNP gene, and specifically their own PRPC that becomes misfolded into a PRPSC. And so the ones that have been documented in humans are Kuru, Creutzfeldt-Jakob disease, Gerstmann-Straussler-Schenker syndrome, and fatal familial insomnia. All of them have to do with the human PRPSC. Historically, one of the earlier studied diseases was scrapie in sheep and goats, and this is where the SC denotation comes from for the misfolded form. Now, another TSE that has been documented in humans uh, is the variant, or the new variant, Creutzfeldt-Jakob disease, as you'll see on a follow-up slide, and that has been associated with acquiring the prion from cows, the bovine spongiform encephalopathy disease, which is colloquially referred to as the mad cow disease. And so some people believe that we acquire this from the cows, and hence this is why it's called the mad cow disease. The first TSE that we'll discuss, the first human TSE we'll discuss today, is the Kuru. So Kuru has not been seen since the 1970s. I'll explain why in a bit. Epidemics were more common in the 50s and 60s, mostly in New Guinea. Peoples of that region, they practiced mortuary cannibalism, so they would eat their dead. And so that's how they got the disease, basically from consuming we believe, consuming the brains of their dead. Um, and so in the 1970s, missionaries um, came to the New Guinea and they started stopping this practice. And this is how the virus sort of, or excuse me, the disease has sort of disappeared. So like other TSEs, this is a disease that has a very long incubation period. It might take years to decades. It has a very broad range of age of onset. So somewhere between 5 years and 60 years old, the person might develop the disease. The symptoms include tremors, ataxia, which means uncoordinated body movement, dysarthria, which means you cannot really articulate and speak properly. Dementia is rare in Kuru, but it's more common in the other TSEs. Um, and one rather characteristic of Kuru is the laughing sickness. So the person who has the disease would have outbursts of laughter. So after the symptoms start, what happens is death within 6 to 12 months. Uh, and what you're seeing here is the gross morphology of a congested brain blood vessels in somebody who had Kuru. Creutzfeldt-Jakob disease is another TSE. This is the most common TSE caused by prions, but still rare. So 1 in a million people per year develop Creutzfeldt-Jakob disease. And the symptoms, they are dementia, ataxia, dysarthria, as well as tremors. Blindness might also occur. About 90% of patients will die within 12 months after you start the symptoms, but some may be symptomatic for years. And like all of these TSEs, they are slowly progressive, so it takes a very long period of time for manifestations to start happening. So it's a long incubation period of years to decades. Now, these are the histological sections I had promised. This is a CJD. You'll see the pore here. And Kuru, it's more spongiform. You're seeing these blank spaces where the amyloids were. Creutzfeldt-Jakob disease has three types. The sporadic one, which has no known risk factors. So remember that this might happen due to spontaneous conversion of the protein within the cell, or potentially due to a somatic mutation that could happen. Familial CJD, here we have mutations in the PRNP gene, and this is autosomal dominant. We also have the iatrogenic or infectious form transmitted when you have contact with infected tissues. Possibly consuming meats uh, might lead to what we call the variant CJD or new variant CJD. So this is the mad cow disease. So it has been attributed to being exposed to bovine spongiform encephalopathy because if you want to eradicate the prion, the protein itself, you need a very high temperature. So you have to cook your meat at a temperature of higher than 100 degrees centigrade. So you're basically burning your meat in order to get rid of the prion. And even then, you might not get rid of the prion itself. So what about surgery? What should people do? What is recommended nowadays is incubation of surgical tools with bleach or NaOH, and then follow that up with autoclaving. So there are means by which you can get rid of the prion. However, cooking the meat is probably not really sufficient to get rid of the prion itself. The variant or new variant, uh, Creutzfeldt-Jakob disease attributed to exposure to the prion of the cow, uh, has a younger mean age of onset compared to CJD. So CJD, the age of onset is 50 years and older, and the new variant or the variant CJD is about 30 years of age. Depression is a prominent symptom with CJD, with variant CJD. The last couple of prion disorders are the Gerstmann-Straussler Schinker syndrome and the fatal familial insomnia, both of these are extremely rare. They are heritable, they are familial, that is, and they are autosomal dominant. The age of onset of GSS is about 20 years or older. The symptoms here are ataxia and dementia, so similar to the others. Dysarthria, deafness, and blindness may occur, so these are not really distinctive symptoms of this TSC. They are similar to symptoms seen in the other TSEs. This is again a slowly progressive disease. It takes a long period for you to see symptoms once the proteins are being formed. So this is why it's 20 years or older. This is why this is the age of onset. Now, once the symptoms start, it takes about 2 to 10 years before death happens. As for fatal familial insomnia, also similar to the other TSEs, but what's happening here is that we have plaque formation in the thalamus, and the thalamus regulates sleep, so the person has progressive insomnia, and of course this is quite bad for anybody's system, and so this results in dementia and then death within 3 years of onset. The onset mean age of the disease is about 50 years of age.